Statins is the most important class of antilipidemic agents. It is the only class clinically proven to reduce the cardiovascular risk. Use of other classes of antilipidemic agents is mainly based on speculation that reduction in cholesterol may reduce the cardiovascular risk. In this lecture, we'll discuss mechanism of action of statins, their effects, efficacy, use, adverse reactions, nature and size of the benefits, risk-benefit ratio, and role in multifactor intervention strategy to reduce the cardiovascular risk. During last 15 years, the consumption of statins in Lithuania increased more than 15 times. The consumption of rosuvastatin increased more than 50 times. In 2023, more than 14% of Lithuanian population received statins on daily basis. If we know volume of sales, defined daily dose, and the size of the population, when we can calculate how many subjects take the specific medicinal product. At this slide, you see the results of such calculation. Defined daily doses per 1,000 inhabitants of Lithuania. Defined daily dose is a usual daily dose for the main therapeutic indication. Before continuing the discussion on statins, look at the full list of classes of antilipidemic agents. All of them have been demonstrated to reduce cholesterol levels. However, they are never proved to reduce the cardiovascular risk nor overall mortality. Furthermore, a large randomized controlled clinical trial did not demonstrate any additional clinical benefit of nicotinic acid addition to an existing statins regimen. Instead, with more prominent reduction of plasma cholesterol, such reduction increases the risk of serious adverse reactions, including intracranial bleeding, gastrointestinal bleeding, myopathy, infections, and diabetes. Based on the results of this trial, use of nicotinic acid as antilipidemic agent was prohibited in the European Union. Surprisingly, the Food and Drug Administration of the United States of America made an opposite decision and kept nicotinic acid on the market as antilipidemic agent. The reduction of plasma cholesterol has no value unless it is associated with cardiovascular risk reduction. So, lifestyle interventions should be applied before starting drug therapy. Contrary to drug therapy, they do not cause adverse reactions and provide overall health benefits. First, let's have a look on the cardiovascular risk factors. So, hyperlipidemia, hypertension, diabetes, which increases the risk of coronary heart disease at least twice, sedentary lifestyle, inappropriate diet such as excess of saturated fatty acids, trans fatty acids, highly processed foods, sugar, etc., obesity, smoking, which increases the risk of coronary heart disease at least twice, and also congenital disorders. Most important lifestyle interventions include physical exercise, appropriate nutrition, and getting rid of smoking. Management of those three cardiovascular risk factors, so sedentary lifestyle, inappropriate diet, and smoking, This provides a lot of help in managing others. Exercise and appropriate diet helps to reduce plasma lipids and glucose, blood pressure, and body weight. In this way, one can control hyperlipidemia, hypertension, obesity, and even type 2 diabetes. To decide if a subject requires an intervention to reduce the cardiovascular risk, first we need to estimate this risk. There are various methods for that. I provide you an example from the British National Formulary, which estimate the risk of major cardiovascular events over next 10 years. For the estimation of the cardiovascular risk, in accordance with these nomograms, one needs to know subjects' sex, age, systolic blood pressure, status of smoking, status of diabetes, total plasma cholesterol, and high-density lipoprotein cholesterol. When we eat, we get some lipids, and there are nascent or growing chylomicrons in intestines. They have been absorbed into the blood and circulate as lipoproteins because lipids are not soluble in plasma. You see structure of chylomicron. They contain here cholesterol and its esters as nucleus, then triglycerides, main component, also phospholipids and proteins here. Then, with the activity of enzyme lipoprotein lipase, chylomicrons lose their triglycerides, and finally we have only chylomicron remnants, which come back to the liver and then once again gain triglycerides and are converted to very low density lipoproteins. They are secreted as very low density lipoproteins. So, what is the difference between chylomicrons and very low density lipoproteins? Actually, it's composition. Its composition, you see different size and different percentage of cholesterol, triglycerides, proteins, phospholipids in these lipoproteins. Very low density lipoproteins undergo similar pattern of metabolism in plasma. Once again, lipoprotein lipase metabolizes their triglycerides and convert very low density lipoproteins to intermediate density lipoproteins and finally to low density lipoproteins. You see here that low density lipoproteins contain high amounts of cholesterol. Low density lipoproteins have also apoprotein B100, which attaches to LDL receptors both in the liver and peripheral tissues. So after this attachment, LDL enter cells via endocytosis, and he has been used for the synthesis of cellular membranes, calcitriol, and steroid hormones. Note that there is no way of elimination of low density of cholesterol from peripheral tissues. The only tissue, only organ which is capable to eliminate cholesterol is liver. Hepatocytes are capable to eliminate cholesterol because they use it for the synthesis of bile acids. It is considered as most important effect of statins is effect on LDL, on low density lipoprotein. And let's have a look on the mechanism of this effect. Statins act as competitive inhibitors of the enzyme hydroxymethylglutaryl-CoA reductase, and this is a rate limiting step of cholesterol synthesis. So they reduce the synthesis of mevalonic acid, synthesis of cholesterol. If we have less cholesterol in the liver, then the hepatocytes adjust their function to get more cholesterol. So they increase the synthesis of mRNA for receptors of low-density lipoproteins. So here in endoplasmic reticulum, on ribosomes, we have increase in the synthesis of LDL receptors. Then increased amount, increased number, increased density of LDL receptors on hepatocytes cause increase in clearance of LDL from blood. So liver uptake more LDL and more cholesterol. So this is the reason why LDL in plasma has been reduced. Another reason is that if cholesterol in hepatocytes decreases, then the synthesis and secretion of very low density lipoproteins also decreases because cholesterol is necessary for the synthesis of very low density lipoproteins. Just you need to consider that the liver produces just very low density lipoproteins. It does not produce low density lipoproteins. Low density lipoproteins have been produced in plasma from very low density lipoproteins under influence of lipoprotein lipase. Next slide, effects of statins and pharmacokinetics. I would say that we need just a general idea of the slide. There is no necessity to memorize anything here. And if somebody asks, what is the clinical importance of different effects on plasma lipoprotein profiles of various statins? I would respond, nobody knows. Biochemically, it is clear, but in terms of cardiovascular morbidity and mortality, it is not proven. To show that one drug is superficial to another one in terms of cardiovascular and morbidity and mortality, we need direct head-to-head comparative clinical trials. There are no such clinical trials to compare one statin with another. So we cannot tell that atorvastatin or fluvastatin is better or worse than other statins. Maybe we can assume something in accordance to changes to plasma lipoprotein profile, but it is just assumption without any clinical evidence. And also we should note that for statins, other mechanisms may also be important, such as reduction in oxidative stress and vascular inflammation, because coronary heart disease events are reduced more rapidly than changes in morphology of arterial plaques occur. And specifically, we remember that statins reduce the synthesis of cholesterol, which is critically required for the synthesis of steroid hormones, of calcitriol, of cellular membranes. So they absolutely contraindicated during pregnancy and lactation because loss of statins, loss of cholesterol would lead to disturbances in formation of these substances in unborn child or in breastfeeded baby. Therapeutic uses of statins. First, I want to emphasize that solely hypercholesterolemia is not indication for the use of statins. And before administering any medicine, we should consider its risk-benefit ratio. We always should consider what benefit do we expect and how was this benefit demonstrated already. So there are several therapeutic uses of statins. They differ among different products a little bit, so I made some generalization, and I suggest to stick to the materials of this lecture regarding therapeutic uses because they sometimes are not so clearly described in textbooks. So first therapeutic use is treatment of primary or familiar hypercholesterolemia or mixed dyslipidemia in adults and children over 10 years, always as adjunct to diet and other oncological. So this is quite specific indication in specific population which has congenital disorders which didn't have any cardiovascular event yet, so it is primary prevention. And it is very long-term prevention because, of course, so young people do not have usually cardiovascular problems yet, but they probably will have them earlier than other people. And it is also question when should we start therapy, because children need cholesterol for their growth, for synthesis of hormones, of cellular membranes. Still, about 10 years is considered to be adequate age for the start of therapy. Next use is once again primary prevention, but it is those are people without congenital hyperlipidemias. They just have high cardiovascular risk because of different reasons, maybe because of concomitant diseases or their lifestyle. Meaning of high cardiovascular risk means several risk factors. In the beginning of this lecture, we have discussed these risk factors, such as smoking, hypertension, diabetes, etc., etc. So, in addition to correction of other risk factors, statins may be administered. Primary prevention. So statins reduce cardiovascular risk in high-risk patients without clinical cardiovascular disease. And the last therapeutic use is secondary prevention. So secondary means after occurrence of first cardiovascular event. So those patients are with history of myocardial infarction or unstable angina, but once again, as always, as an adjunct to correction of other risk factors. This is the reason why we give so much attention for them in the beginning of the lecture. So, in which patients do benefits appear? In what percentage of these patients? And actually, what benefits? We already know in which patients. Of course, in patients in whom statins have been indicated. So we discussed therapeutic uses, and we should stick to them because benefits in other patients are not proven. If benefit is not proven, then we cannot judge if this benefit we can expect to be higher than risks or lower than risks. So definitely in the absence of therapeutic indication, yes, physicians sometimes may administer drug in the absence of therapeutic indications, but then it takes its own responsibility. Sometimes it happens that therapeutic indications is on the way of marketing authorization. So if physician knows some data in addition to data in summary of product characteristics of authorized products, then he may use this data, but once again, it is his own responsibility. Normally, we should administer any drug only in patients in whom the drug is indicated. Then, in what percentage and what benefit we'll discuss in the next few minutes. There is some specific study of atorvastatin. If you remember well, atorvastatin is the statin which has been most commonly used in Lithuania among all antilipidemic agents. And this is design of the study. Always when we discuss any study, we need to know the design. What does it mean? Randomized, double-blind, placebo control. You may have a look into general pharmacology. So they studied the prevention of cardiovascular events in adults who are estimated to have high cardiovascular risk, and always in adjunct to correction of other risk factors. In any study, there are inclusion criteria, so specific conditions which should be present. Yes, there are also exclusion criteria, conditions that should be absent. So all patients were hypertensive, there is specific age interval. This is primary prevention study, so no previous myocardial infarction or treatment of angina. There is specific total cholesterol level, not very high. And next bullet, at least 3 of predefined cardiovascular risk factors and those factors and list of these factors. So hypertension, age, so etc., and 3 of predefined cardiovascular risk factors. And then this Subjects have been treated. First, antihypertensive therapy, amlodipine, calcium channel blockers or atenolol, beta blocker based regimen, and either atorvastatin 10 milligrams daily or placebo. And these are results. In test column, you see endpoints of the study, and then assessment of the benefit in respect to this endpoint. We have a relative risk reduction. We have a number of events. We have absolute risk reduction and p-value to demonstrate that the difference is statistically significant. And one more statement. Median duration of follow-up was 3.3 years. So what does it? Let's have a look just on the one endpoint on fatal coronary heart disease plus non-fatal myocardial infarction. So those are patients who died from coronary heart disease or who survived myocardial infarction. Now let's have a look back. So this is number of patients who took atorvastatin, 5168. Atorvastatin, 5168. Placebo, in addition to antihypertensive therapy, 5137. Then number of events in atorvastatin group was 100. In the group of placebo, it was 154. Now we calculate the percentage of patients who suffered from event in the atorvastatin group. So it was, let's divide 100 to 5068. And we get 1.93%. This is absolute risk. So with atorvastatin, this percentage of patient got fatal coronary heart disease, so died from coronary disease, or had not fatal myocardial infarction. Now let's calculate the same for placebo. And the result is 3.0%. And this is the difference is absolute risk reduction. This is a roundup in the table. 1.1%. Now let's calculate a relative risk reduction. We rescued 0.7% of patients from those three. We divide 1.7 by 3 and get 35.6% as a relative risk reduction. In the table, it is rounded to 36. We can go in similar way with other endpoints, but conclusion regarding first endpoint in this table is clear. 1.1% of patients benefited from our therapy in terms of fatal coronary heart disease or non-fatal myocardial infarction. By the way, usually similar methods have been used for the estimation of efficacy of vaccines. So if one says that efficacy of vaccine against COVID is 95%, so it is usually a relative risk reduction, and it is calculated in this way, which I have explained right now. And then we continue with the results of this study. Despite the reduction of fatal coronary heart disease, total mortality was not significantly reduced. Cardiovascular mortality was also not significantly reduced. Other statement, benefit was seen only in males. And also, one more limitation of this trial, the primary endpoint was significantly reduced in patients treated with amlodipine-based regimens, but not in those treated with atenolol-based regimens. Always, once again, when we administer drugs, we should consider data of clinical trials. Of course, it is not only clinical trials with atorvastatin. There are several another clinical trials also on another therapeutic indication. There is one trial on the same therapeutic indication, but this one was pivot clinical trial, so most important clinical trial. And it is always clinical judgment. Could we extrapolate the data of on certain populations to another populations? Well, I made some abbreviation in the slides for this lecture. Let's have a look on the full data of which appears in summary of product characteristics. Let's go to the summary of characteristics of this atorvastatin. Electronic Medicines Compendium of United Kingdom. It is here. Easy. EMC. We type EMC and UK into the browser. then look for data. Clinical data as well as mechanism of action always appear in the section of summary 5.1 of summary of product characteristics. And now we find the same study which we discussed in the lecture. The same description. I just go specifically to what is said about limitations of the trial. So it is said later that in subgroup analysis by gender, a beneficial effect of atorvastatin was seen in males, but not in females, possibly due to low event rate in female subgroup. So they tell that there was too low number of events of deaths or non-fatal infarctions to show benefit in females. It looks nice, but have a look on the next sentence. Overall and cardiovascular mortality was numerically higher in female patients. So this means that there are more females who died in the treatment group in comparison with control one. Okay, it doesn't matter anything. It wasn't statistical significant. It wasn't statistical significant, but we have absolutely no any proof of benefit in women. And also, there was significant interaction by antihypertensive baseline therapy. If we go to the summary of product characteristics and try to have a look to undesirable effects, we'll see that they are very lot. There is no chance and no necessity to remember everything. If we choose what should we remember, we always choose major adverse reactions, so those what are relevant for the assessment of the risk-benefit ratio. We already discussed benefits of statins in terms of cardiovascular morbidity and mortality. Now let's discuss serious adverse reactions that may also significantly impact morbidity and mortality. So first of all, there is muscular damage. Myalgia and myopathy is not a problem as long as there is no rhabdomyolysis. But myalgia and myopathy may be initial manifestations of the development of rhabdomyolysis. So in such cases, we need to make laboratory check of the enzyme creatine kinase, which is produced in muscles, and if it appears in plasma in high amounts, it can show damage of muscles. So in severe cases, rhabdomyolysis may appear. Rhabdomyolysis is destruction of skeletal muscles. Myoglobin, blood. Myoglobin may filtrate into through glomeruli, appear in renal tubuli, make the obstruction and cause acute renal failure. So this is the reason why muscular damage is so important, and we always should consider the risk factors which appears in the slide if we discuss the risk of muscular damage in individual patient. Then next major adverse drug reaction is type 2 diabetes. Well, a population which takes statins, he has already increased risk of diabetes. As many as 2 2% of patients who take statins for primary prevention in high-risk population, or for secondary prevention following cardiovascular events. So as many as 2% of such patients have new onset second type diabetes during study. But meta-analysis of different studies demonstrated that statins increase this risk approximately by 0.5%. So we have 0.5% of additional cases of diabetes in 3 or 5 years. And actually, such frequency is uncommon. But if we have a look on some SNPCs, they show that it is common, because actually the development of diabetes is common. Those 0.5% have been added to background incidence of 2%, and we have about 2.5, and this is common. And finally, the risk of hepatic toxicity and, in rare cases, liver failure.